First of all, I want to present myself. I'm Shmuel Dekel, orthopedic surgeon. I'm Oxford graduate, so I was aware of the Oxford UNI from the 1976 when I was in Oxford for a few years then as a lecturer in Oxford. And I want to tell you about preoperative planning of Oxford UNI using the TraumaCad software on MRI images. Currently, this is not done. And I think it's a very good opportunity for you to show you how can you plan preoperatively half a knee or partial knee replacement using the TraumaCad on MRI images. Now, as you know, there is no comparison between partial knee replacement, the result achieved by partial knee replacement and full knee replacement. Those ones who are achieved by partial knee replacement are by far better than a full knee. That's in my experience. And I'm using the Oxford knee now for almost 42 years. Now, what are the advantages of preoperative planning? It is possible to measure the posterior slope of your tibia. Every one of us have a different slope. The correct size of the implant can be estimated, and this is particularly important if you have an extra large person or extra small person. You may not have these implants in your backyard. So it's very good to preoperative plan in these situations. Secondly, you can predict if the bone defect that you have on the medial side or the lateral side is good enough to do the half a knee replacement. So that's a very good thing too. Now that's one example, as you see here. You see that this is an anteromedial osteoarthritis, classical anteromedial osteoarthritis classical of a patient, very young patient, 62. And you can see that preoperative planning is showing, in fact, that you can really achieve a good result by using UNI. But you could estimate exactly what size of implant you need and how can you cut the tibia, for example, which has a very significant defect on the anterior part. So if you do it, for example, this is the operative planning, you can see immediately that the tibia which is planned is D, and the femur which is planned is large. Okay, so I know from the beginning that the slope is this is the slope of the cut of the tibia, and the femur is large. And this is the bone which was removed, and you can see immediately that very small bone was removed from the front and very big bone was removed from the back. In fact, this tibial plateau fractured here because it was very difficult to remove the posterior part which was thicker, and this is why it fractured. And this is the result. This is 62 years old, and exactly the implant used is large femur and tibia D. That's cementless implants used in this case. I usually use cementless implant. Now, this is another case, and you see, is this patient good for UNI? You can see anteromedial osteoarthritis again. Something in the back is okay. There is a big cyst here, bone cyst here, and I wondered if this will be okay for UNI. And you can see that I was able, by preoperative planning, to ensure that I can use a cementless implant here. And this patient is a hard worker, very young one, which is still working very hard today. And in Israel, we have a lot of patients with AVN of the medial femoral condyle. This is something which is probably hereditary to some extent, because while working in England, I came through very few cases of a vascular necrosis with need partial knee replacement. And you can see a few cases here. This is suitable for UNI, yes or not? Yes, it is possible. If you see, even this defect can be covered by UNI if it's especially very anterior. So you can really pre-plan your surgery very well. There is two ways to calibrate the images. One by known diameter object, which we do today, and calibrated the MRI images. All the MRIs today are calibrated, so it's very easy to preoperatively planning on the MRI images. This is what you can do by just an object. You can find it and you can really calibrate it and decide which knee you need, but it's much better to do it on MRI images. You can choose the proper cut to estimate the correct size of the implant. For example, to choose the correct size for the tibia, you need more lateral cut, more next to the intercondylar eminence, while for the femur you need it in the middle of the femur. So these two sagittal cuts to plan the tibia or femur are different. So you have to plan it differently. For example, this is a very good cut for the femur because it's in the middle of the femur, but it's bad for tibia because this is in the center of the femur or the sagittal cut. This is much better for the tibia because it's more close to the intercondylar eminence. So if you plan your thing, and you see again down here that the lateral side of the knee is perfectly okay, and all the damage is bone on bone on the medial side here. So this is a very suitable case for uni, but the cuts that you plan, the tibia and femur, are different. And here, for example, if you plan your femur, your tibia here on a cut which is suitable for femur, the tibia will be very small. It's only B. If you plan the femur on the cut which is suitable for tibia, the femur will be medium. So you have to change the cuts in order to, and this is very well demonstrated here on this slide. And you can see that this cut is suitable for the femur because it's in the middle of the femur. And this is cut suitable for the tibia, which is slightly more close to the intercondylar eminence. This is how you plan it. Now this is extremely important in patients which are extremely tall and big or extremely small. This patient is a basketball player, which is 2 meters and 10 centimeters tall. Of course, I may have not the right size for him. And only preoperative planning showed that actually you need an extra large femur and a tibia F, which is the biggest size available in Oxford UNI. If I didn't have that size, it's probably in the back of the operating theater, or maybe not available, I couldn't do UNI in this case, which is still playing, he's a referee in a basketball games today all over Europe. So preoperative planning is very good for these different people which are very small or very small or very big. So the intraoperative measurements done today are the spoon, as you know. But if you have a very big damage in the front of the femur, the spoon is not going to give you the right size. If you do it on the MRI images and follow the posterior curve of the femur, it will be much more accurate. Okay, so it is the size of the tibia. Of course, you can really plan according to the piece of bone you have removed, provided you remove it in one piece and not small pieces, which sometimes do happen. So what we decided to do is just to see how accurate we are in the preoperative planning. We're using the TraumaCad. And we choose patients with MRI images, and we looked what was planned versus what was implanted. And we had 70 patients. You see femurs and right and left. And this is the sizes which are really implanted during surgery. This is the femurs and the tibias on the right-hand side. And we looked how accurate was the preoperative planning. In femur, it was correct in 69 out of 70. So we're very good in planning the femur. What we choose when we use the spoon and the preoperative planning on the MRI images is very accurate, correct, concerning the femur. And only one case, a large femur component was put and medium was inserted. In the tibia, the accuracy was slightly less. In 64, it was correct out of the 70. In 5 cases, we choose a larger size. As you know, especially in cementless implants, we'd like to use a larger tibia as possible to cover the entire surface of the tibia. That's very important. So probably we didn't estimate correctly in some of the cases the size of the tibia. And during surgery, we choose to use one size up in 5 cases. In one case, it was less than that. So it's extremely important to choose the correct tibial size and cover the entire tibial surface with the implant in order to avoid subsidence of the implant. In conclusion, preoperative planning using the MRI images has few advantages. It's very accurate regarding the implant used in the femur. Less is the tibia. Possible to assess if Oxford UNI is suitable if in cases of bone defects, and the tibial slope can estimated in our study it was about 5 degrees posterior slope. And after a good uni, you can even do extreme sport activity as this patient is running marathon. Thank you very much.